QALYfied, Episode 0. Nerds Do a Podcast. A quick note from Augustus here. In the podcast, we throw around the terms QALY and DALY rather casually, and sometimes stray away from the absolute definitions. So I wanted to just add a definition and a clarification here if you haven't encountered these terms before. QALY, spelled QALY, is an acronym for Quality Adjusted Life Year, which is a measure of the quality and quantity of life lived. A QALY of 1 is living with perfect health, and a QALY of 0 is death. DALY, spelled DALY, stands for Disability Adjusted Life Year, which is a measure of disease burden. DALY is calculated by the years of life lost and the years lived with disability. That's about it. Once again, in the heat of the discussion, we might use the terms loosely and broadly, but rest assured, we do know what they mean. And now, you do too. So on with the show.
Should we talk about what we want to like names or like any of those like type of things?
We should do some, I don't know. It's either, I think this is going to be a process to come to a name that we like.
Of course.
It could be a terrible pun.
Oh,
Well, I guess it kind
Rice
of depends
to meet
on
you.
if
Wait,
you want it to be serious or not.
No, have you heard of the podcast called Rice to Meet You?
No.
So it's like it's the Malaysian comedian that I was talking about, the one that was like talking about the rice. So they have a they have a Zoom podcast and it's called Rice to Meet You. The only Asian comedian podcast.
Well, I think that's the thing. It's like, do we want this to be sort of like entertaining, or so for light sort of content for people who are sort of on the surface interested in the industry?
Yeah.
Or is it meant for industry?
Well, what kind of names do you think are? I mean, because you've had a look at a couple of different podcasts, so like, are they kind of like podcast names that you find are effective? I guess I don't know, because I do like, I mean, to be honest, I mean, I do like some of them that are a bit that sound ridiculous. Like okay, so there's one that I have called Get Rich Nick, which is funny also because both of the hosts are called Nick.
Okay. Let me open podcast.
You look at your podcast, okay.
Yeah, I mean, like, if you look at so I'm just looking at the categories, right?
Yeah.
So if you look at business and technology categories, they're all like sort of pretty serious names, basically,
like what?
right? World Business Report,
Oh,
I think the least serious one on here is Market Foolery, which is by the Motley Fool, which is not even like,
that's not even that.
Now it's like a brand,
Yeah.
It's like, it's got a big thing now.
Yeah.
Pivot, Daily Stoic, let's say Reply All.
Oh, I have Reply All. Oh, did I? Oh, yeah, I love Reply All. Yeah.
So yeah, like again, if you want business and technology, like it's all the names are pretty heavy. Let's put it that way.
Yeah, but they can't be too generic, right? Because if it's called like Business World Daily News Times of.
Well, some of them are called that because they
That's
are
awful.
by the Times.
Okay, that's seriously awful. Okay, but that's because the Times is a brand. So like, it's like you're not looking for Business World Daily News of the Times. You're actually looking for the Times, and then you get the podcast.
Yeah. So it literally says, like, I'm looking down these things, and it's even even under educational.
Yes.
A lot of it is still pretty serious. I mean, I like ologies as a name because it's very descriptive.
I like ologies, but the sound of the word is a bit like ologies. I know what you mean.
But it makes sense for the theme of what she's doing. So I think
Yeah.
it works really well.
Mm.
You know, like, so there's other stuff like, you know, the Anthropocene,
Yes.
which is obviously, you know, certain
Yes.
demographic.
The paleo,
Yeah.
not the diet, but the paleo specialist.
Yeah. The
Demographic.
Happiness Lab, you know,
Yeah.
Myths and Monsters.
There's okay,
right?
so there's one from Marketplace called Make Me Smart, which I like.
Yeah.
That's
This one's kind of interesting. It's BBC4 Radio.
yeah.
And it's called You're Dead to Me.
Oh,
and
I like that.
Right?
Okay, I actually want to search that now.
So that's pretty good.
Yeah.
You know, and it's historic is, you know, but it's it's comedic, right?
Yeah.
And I feel like maybe that's how we have to think about it. Like, how would a British person name this podcast?
Yeah. So you
it's
have
kind of like
you have a word, and it's a kind of like it's not punny, right? Because You're Dead to Me is not punny, but you're using the word in a catchphrase of some sort. So that's kind of so it's kind of like it gives you a sense of the subject, but actually the title is a non sequitur from the subject.
Yeah.
Okay. That's a good.
So
that's a good.
see.
Okay, that's a good lead. Actually, that's a really good lead.
Okay, now I'm under society and culture. Behind the scenes, in my opinion, let's not meet, which is
wait, is it a podcast about meat?
No, it's actually a horror podcast. It's a horror podcast.
Oh,
I actually don't. Yeah.
Okay.
So
should we have something that has a word has a health related word to it, or a device like risky business?
No,
class
no,
1,
I got
class
one.
2.
No, I got one.
Okay.
Informed consent.
Informed consent. Getting hippo with it. I don't know. That's so stupid. I wish I didn't say that.
I kind of like informed consent because it's literally that's the entire industry.
Okay,
like, that's whole industry is about informed consent.
So explain to me as a non-healthcare person what is informed consent.
So at the most basic level,
it sounds like dating on a campus college campus.
Oh, it's kind of that,
okay,
to be honest. But
it keeps you from a little bit.
Well, it keeps you from litigation. Okay, so basically the whole it was just like almost the entire you know, especially Western medical world, and how why there's regulations, why there's pricing and reimbursement, why there's IRBs, you know, why are there basically boards in hospital settings? Why do they have SOPs? It's basically all because of this. It's basically the fear of getting sued. So the whole industry.
Fear of getting sued.
Yeah, to be honest, it's the base of most of the Western world's medical industry. So informed consent at the most basic level is when a doctor comes to you and says like, "Hey, you have cancer. So I suggest these treatments."
Hey, you have cancer.
Yeah, but that's kind of how it goes.
Hey, you have cancer.
Yeah, and then they go, "Okay, we recommend these treatments, but here, let me tell you about the awful side effects.
Yeah.
And your chances of you know, surviving if you do this regardless of the side effects."
Yeah.
That's basically informed consent. It's basically agreeing for somebody to let you do, like, giving somebody chemo is a pretty terrible thing to allow somebody to do to you.
Well, also letting them die of cancer is probably pretty bad as well. But
exactly. So it's all about risk reward, right? Yeah. And so this is why it's called informed consent, because we are trying to save you, but it is pretty terrible.
Yeah.
And there's still a chance that you're still going to suffer and potentially die.
Okay.
So the whole industry is basically built around like, you know, do you really want to do this?
Do you really want to do this? Yeah. Do you really want to take chemo? Okay, fine. It's true. I like it.
So from like a patient perspective, the first time you ever heard of informed consent is that first time you have a problem, you are at the doctor's office, and it's something significant enough where in the Western world they would say, you know, I have read basically the risk to this surgical procedure. I agree with them, basically. So I've been informed that there is potential bad, consequences to doing this as well.
Actually, here's a question on informed consent and how it is delivered, I guess, because so I mean, it sounds like something that maybe the nurse or the doctor has to deliver to you in person, like they read out your rights, or I don't know, like they give you the scenario, like this is the scenario, they give it to you in person. But why don't they deliver it on a video, for example, or like a pre-recording? And I give you an example. It's like when I'm taking a loan from my bank, I call up, and then there's a section where the sales rep goes like, okay, in the next, like I'm gonna play the pre-recording, and you listen to it for 10 minutes. Do they
do that.
Oh, they do
do that.
I had no idea.
But the most common place you see the pre-recorded is in drug ads.
Oh yes, for sure.
Right?
For sure. Yes.
So in certain countries, you're not allowed to do advertising for drugs in public. So basically, it doesn't exist in some countries. I'm pretty sure Singapore doesn't allow it.
Yeah.
But here, it's all over the place. You watch TV for half an hour,
literally
you
all
get
over
6 drug ads.
Yeah.
Literally all over the place. And it's like the entire minute video where they show somebody like walking around, like, oh, if I took, I don't know, Xanax or something, I could be happy too, like this kind of stuff. And then like, almost a whole minute in the background, they're reading basically informed consent. It's like, yes, even taking this, you still could be depressed. You could cause yourself to suicide. Yes, you might get nosebleeds, so it's like, the entire time, it's basically all informed consent.
Yeah. But isn't there a pushback against that as well?
Well, in the United States, I think, unfortunately or fortunately, pharma has a very strong lobby. Sure. So I still see drug ads. I don't think that has changed.
Okay.
It's still very, very common.
Okay.
Informed consent, the other place that happens a lot as well is in clinical trials.
Yeah.
Because obviously you're trying something new on people, so you need to explain to them the risks.
For sure.
So that's also a big part of it. And I tend to use this term when I talk to clients sometimes because, you have to make trade-offs, right? Sure. And consequences are not always rosy.
Sure.
It could go all wrong.
Yeah.
So sometimes client wants to do something that, basically all the consultants basically on my side, all the technical people say, this is a terrible idea. Jeez. But they still desperately want to do it. Yeah. So the only thing that we can do is basically say, well, okay, let's do informed consent. Let me tell you in full why this is a terrible idea. But you are the client paying us, so if you want us to do it, okay, we'll do it. So it's a big part, I think, of expectation management, which I use it now probably because I've been in the industry too long. So I use it broadly, not just in the industry speak, but basically it's expectation management.
Right.
So it might be interesting for people who are thinking of maybe joining the medtech industry to hear some stuff where it's like, yes, it's a good industry to work in, but realize that at the end of the day, for the most part, you are still making rich people live longer, not necessarily improving everybody else's lives.
Yeah.
Right? That is still the state of most of medtech and pharma. The stuff that gets investment in tend to be, let's say, rich, usually Caucasian, usually more male demographics. Okay,
but you know what?
That might be interesting.
I feel like this sounds really crazy, and maybe I'm drawing like I'm reaching or something. But I feel like that applies to so many different things, not just in healthcare. Because when I'm doing investments, for example, we're identifying the risk of the investment at the stage, because you're going early, that maybe 70% of it's there and 30% is not there. And you're doing, this is what we call the mosaic theory, the mosaic approach for information gathering, where you're taking lots of different data points and you're making an investment thesis. So no one's telling you to invest in something per se, but you're creating a thesis with these different points. And when I present it to either my supervisor or to our investment committee, I'm always making certain caveats when I'm talking about it. So like, the size of the market is this, according to a report, assuming that the report has been done on a reasonable population size, with reasonable standards, or this is likely to be has a high potential of being commercialized at a certain price point, assuming this cost benefit analysis that we've done makes certain kinds of things. So I'm informing you that this is it, and these are the parameters of which is correct, and maybe the assumptions, and also the scenario, but also implicitly suggesting the scenario in which it may be incorrect. So
yeah, I mean, basically, if you go into the world of consulting, it's basic, it's what they call expectation management.
Expectation
right?
management, yeah.
Right. They're trying to give you all the facts so that when it blows up, it doesn't blow back on them.
Yeah.
Right. And that's basically informed consent. It's telling you what could go wrong, so that when it does, you don't come after me. And it is everywhere. I mean, it's just that in some ways you don't go to a law firm and be like, informed consent, like for their services. But in medtech, if you say informed consent, all the doctors know what it means. Basically all of industry knows what it means. Definitely their lawyers know what that means. So and patients know what that means as well, or should do if they are actually patients.
And when you're talking about, so let's say when you're talking about a new device, right? And you're going through the clinical phase. You're doing the testing on maybe some kind of a pilot patient population, or maybe even, I don't know, animals or something. But when you go into that, you also have IRB, right? Which gets through the ethics board. So doesn't the ethics board process, the IRB process, also play a role in kind of pre-evaluating before it gets to the point of the patient? Because they're not going to approve something that's fundamentally unethical from a cost-benefit analysis perspective.
Yeah, but like, everybody has different risk profiles.
Sure.
And they have different things that they want from their life, right? So for some people, if for cancer is an easy one to talk about, because this is where some hard choices need to get made.
Yeah.
So they say you get diagnosed with a form of cancer, and then basically you have a choice. You could do this rigorous regimen of chemo plus other cocktail of drugs, which means that you have an atrocious quality of life for 6 months, 9 months, potentially. But potentially you could come out the other side and you could go into remission and give yourself another 3 years or 4 years of life, of good quality life after that.
Right.
But there's no guarantee. So potentially you could go in and have horrible 6 months, like zero quality, like you can't do anything except suffer. And then at the end of that, you die. Right. So some people,
why am I laughing at that?
I don't want to do that. I want to enjoy the last 6 months of my life, and I want to do that the way that I want to do it. I don't want to be in hospitals. I don't want to rack up this gigantic bill that puts my family in debt. I don't want to do it. So that's basically informed consent.
Yeah.
So is it ethical to offer that treatment to patients? Absolutely. Because it does statistically give them a fighting chance, at least, of coming out the other side. But what percentage that's acceptable, what success percentage is acceptable to each individual, is down to them to decide. And that's why informed consent is so important.
But if there's such a variability, then what's the threshold that the ethics or the IRB is are they holding it to a lower threshold so that people can build on top, like they're more progressive, and so that people can kind of like it opens up the opportunity to more patients, or even just the possibility of to patients in the first place? Or are they in the median, like, or are they so high that they actually prevent?
Well, it depends. It depends on the ethics board.
Right. Okay.
Right.
Yeah.
Okay. So it depends there, basically, who's on the ethics board. So that is a consideration. but it also depends on what that treatment is for.
Mm-hmm.
So if it's something where high chance that this person is going to die anyway in 6 months, you basically, even if it's a sort of earlier stage exploratory treatment, you might just pass it through the because if you wait 3 years, this person is going to be long dead. And if they don't want to die, this is their only chance. So it really depends. But then there's other things, for example, that it takes years to do your clinical trials. That's right. Because the success of existing treatments is so good already. For example, statins, or stents, or even asthma drugs. The current treatments are very good already. So the threshold for risk is much lower. And they want to see much longer studies. So statins have been around for decades at this point. So they have a lot of longitudinal data on the existing statins to show how safe and effective it is, and how much you can titrate and all this kind of stuff. So when you introduce something new, you're fighting against that as a baseline. So then you end up having to do a clinical trial that lasts 10, 15 years to just even try to match basically the longitudinal data that the existing treatments have.
So you think that if you're developing a stent now, you're going to have to do a lot more. The bar is higher.
Well, I mean, yeah, and it kind of depends. It's like, what are you comparing against, right? So in some product categories, like orphan diseases, especially congenital ones where kids basically die very young, giving them an extra 6 months, giving the family an extra 6 months is acceptable for the risk. But in other scenarios, it's really not. Extra 6 months for a lot of extra pain, probably not acceptable if this person is still estimated to live to age 70, just not 75. You know what I mean?
Right.
So there's definitely a balance there. And there's also, that's also why clinical trials get done in different parts of the world, because ethics and
because ethics is
money
different.
are kind of different.
Right.
Because again, if you go to somewhere that you have a very large treatment naive population, basically they're too poor to afford any treatment, and you tell them, look, I have a clinical trial, you have a 50-50 chance of either getting gold standard treatment, which you couldn't afford anyway, or this new drug that we're hoping to be even better than the existing treatment. Right. And you couldn't afford any treatment before that. Would you go for it?
I see. So they're considering the accessibility. So they're considering the accessibility of an existing treatment based on some economic circumstance, not just technology without economic to it.
Yeah, and that's why there's there's been some pushback, and there's been some legislation, because you get these rich Fortune 500 companies coming in and then doing a clinical trial in a relatively poor part of the world, right? Yeah. Of course, they're not intentionally trying to hurt anybody.
No, of course
but not. It's obviously, when you run an early trial, that has higher risk profile than running a later trial.
It's practical to do it,
right? So I believe it's India that passed law probably 8 years now, probably somewhere around there, that basically sort of said the company, the entity that is running the clinical trial, is responsible for all treatment of that patient. So for example, if it goes wrong, you have to treat that person with whatever went wrong.
Isn't that not the standard?
Well, not for long-term things, because obviously if you had a surgical procedure and you start bleeding out, of course they're going to try to fix it.
And they have to pay for it.
Yeah, they have, but there's, things that potentially goes wrong later on, because again, let's say you're early stage trial, so you do something where potentially it's a small population of like
Yes.
60 people or something like that. And, it's a short trial because that also tends to be the profile of the early ones. It's a very short treatment duration because they're checking for some of the basic safety things. So fine, the whatever treatment went well initially. And then you later realize that actually there is some unintended consequences that just you didn't see and it doesn't show until a few months later.
Right.
Then what? Right.
Right.
And again, in places that have a very strong litigation culture, like the United States, the company would be all over you to treat you because they're even more scared of your legal fees than they are of your treatment fees. But if you say you're in a place like India, where there's a lot of very, very poor people who don't know their rights, you could just disappear in a way and don't tell them that they can come back for treatment. And then they're forced to suffer with this, whatever it is, consequence. So, it's finding a treatment naive population sometimes is very, very difficult. And so you do go to various emerging markets to get that data. And in some ways it's good because it basically means that at least the treatment was tried out on non-Caucasian populations to see if it works. But it's a business at the end of the day, and so you do try to get away with what you can get away with.
But even if you are doing it in a different market, I mean, in a less developed market, less litigious market, isn't it still standard procedure to have trial insurance, which you would presumably use in the event that there are any adverse events?
Yeah, I mean, I think for all the big companies, they have that. But there are a lot of other companies as well.
Really?
Yeah. I mean, I think most things, it's a very diverse field. We hear about the big names all the time because they get the spotlight, right? But as an industry, medical devices have 5,000 product categories. Now, the vast majority of those are not doing a lot of innovation. It includes everything from tongue depressors and beds, right? So
to masks.
It could be a very exactly, a huge variety of things. So not all categories need the same level of scrutiny for sure. But it does mean that there's a lot of stuff that is just overlooked. And frankly, in most emerging markets, their regulatory agencies are so weak, they are unable to keep up with what's coming through the door. So a lot of them have a registration rather than a review kind of system, which means a lot of snake oil gets pushed into the market, which sometimes is not harmful, but usually it's not beneficial either. So,
okay, that was a long and that was a very meaty discussion. I like informed consent. I do like it. That really works.
I think it's kind of tongue in cheek.
It is. No, now that you've explained it to me, it makes a lot more sense. Yeah, I like it.
I think it's definitely an industry thing. This idea on informed consent, though it's used everywhere.
And it's, like you said, it's also like a way of thinking about things. Right? It's conceptually it applies to many different things in addition to being very important, of course, in healthcare.
Yeah. So that could be an interesting one. I don't know what other names.
Let's keep that on. I like it. Let's use that for now. Let's use that for now unless something truly punnier. No, it's not even punny. No, it's just, whatever. I mean, I like it. Let's go with that.
Okay. Well, we can think about it, but let's go. That's the working title.
Yeah, working title: informed consent. And I think we've got about an hour and a half of recording by now.
Yeah.
Which is good.
It's probably enough for a 15-minute intro.
I mean, like we've got to have like a I've got to figure out how to the part where you kind of have to read stuff out to talk about who you are and what that kind of stuff is. That's something that we can probably work on. We'll just have to script it out. That part is a little bit less fluffy.
Yeah.
So let me. I can work on that part. The structuring of it. Then we can read it out or record it. Then we've got a lot of footage in the middle. And then we can just kind of work on what we want to do for the next one.
Unfortunately, as it turned out, another podcast had already beaten us to the punch with the title that we had our sights on. It was back to the drawing board.
Okay, so let's talk about the name situation. So I know the last we spoke, we were leaning towards informed consent, and we went in a bit about why we thought and I still think it's a good name, but the challenge is that there are other. So the update is that there are other people with the same podcast name, Informed Consent. So that's a little bit problematic. However, I did note that the other podcast is about mental health. It's not so much about what we're talking about, which is devices, the business of devices, and healthcare, and so on. So I don't know. Did you have some other things, other examples that you had in mind? We can talk about that.
So I think informed consent is still my favorite, but I think I did send you a few others on our chat. One idea was in vivo.
That sounds like a Christopher Nolan movie.
I mean, it is a widely used term in industry.
By who?
By industry, because you always have to do whenever you do clinical trials. That's basically your in vivo.
I understand what you're saying. It sounds very clinical, is the thing.
It is. Well, it is very industry. Let's put it that way.
Yeah.
Another idea was disclaimers, which is a little bit tongue in cheek.
Yeah, which could also be the legal podcast by the Legal Society of Singapore. No, I actually thought disclaimers was it's cute. Okay, were those your two examples?
I think I also had QALY, which is very industry.
Yeah,
but that's something that we can, how to say,
qualify.
That's important. I think if that's the theme, if that's the general theme of the podcast, though.
Yeah.
So QALY is quality average life years, right?
Yes.
And the idea is that every innovation that we do in this industry should be improving quality. Right? And that's basically the whole longevity argument, right?
Yeah.
Like how do we, so that our average lifespan is over 100, that kind of thing.
Yeah.
So I know it's very industry, but if we pick that could be just the theme almost.
Yeah.
So like everything is in context of how much is it improving life, basically.
I actually like QALY because it's so industry specific. Like I can't think of anyone else. Or okay, maybe economists. But I'm just thinking whether you can put it in like in a punny way. So the two examples that I thought about, which I can share with you now. One was medically speaking, which unfortunately is very common, and I think another podcast using it as well. And then another one was healthy conversations, which sounds a bit too airy-fairy.
It sounds too wellness.
It sounds too wellness, but I just thought the idea of using it. So I actually like QALY, but putting it in a punny thing maybe is something to kind of lighten it a bit. But we could work on that. But I was thinking the worst case scenario was actually to just go back with informed consent, but because the other podcast is not doing the same exact topic, then there isn't exactly a risk of confusion necessarily. Versus say medically speaking, which is a podcast about something very similar. So that's also possible. I really like QALY, but I'm just trying to think of how to put it in a
something punny.
Yeah. Yeah, like quality conversations. I don't know. So,
Yeah.
QALY, I don't know.
I had to
QALY,
think about this.
QALY me maybe. I know. So stupid. That's so stupid.
Oh my god. Yeah, I had to think about that. It's like, you know, quality, I don't know.
It's close though. I feel it getting closer because that really is so specific.
Yeah. Yeah.
QALY.
Yeah.
We can work around that. At least we've got a bit of a direction. I mean we can
Yeah.
work around QALY. I don't think anyone's using QALY. Let's just
No, it's very niche.
It's
very
so
niche.
niche. Yeah. Okay,
Yeah.
yeah. Maybe we'll,
But
let's
in some ways, like the only reason why I was like that could be
Yeah.
interesting, because if we frame every single session
Yeah.
around how much does this actually improve life, you know, like it basically does. You have
High
a bit of a
quality, low quality.
yeah, you have a bit of a running, you know, like a running theme, so to speak, right?
Yeah. Is it quality? Not. Okay. Actually, no. I really like it now. No, I understand what you're saying, and I'm just trying to think about how we can use it. Okay,
Yeah.
let's work on that. I think that's a really good kind of like a very specific. Okay, the good news is that really nobody's using QALY. I think QALY is a good one.
Uh-huh.
That's a good one. Okay, let's workshop that. And
Well, yeah, QALY and DALY, those are the two, right?
oh god, DALY.
Yeah. So if you want to make it like a roly-poly name, basically, you know, like it just
That's
homonyms.
so weird, QALY and DALY.
Yeah.
Do people really say it out loud?
Yeah.
Do people really say QALY and DALY? Give me an example.
Because it's much better than saying quality of average life year and death associated life year.
So give me an example of when you last heard someone say QALY.
Well, it's usually in the context of reimbursement and so reimbursement, insurance, you know, that kind of stuff.
Yeah.
So whenever you're trying to do a business model.
Yeah. But do they use it as a verb? Do they use it as a noun? Do they?
I think noun. You know, what's the QALY?
What's
basically.
the QALY?
Yeah.
Is the QALY good? Is it bad? Is that what? Is that, how do you use it? Like, just kind of like explain to me how you're encountering it.
Usually, like, so it's kind of a long history.
Okay.
And kind of arbitrary, but this is the history of a QALY. Okay,
yeah.
So way back when, people were dying because their kidneys were failing.
Okay. Yes.
And dialysis was invented, but dialysis was very expensive.
Yeah.
Okay. So expensive that basically people were like, can we justify paying for this?
Yeah.
Okay. And Medicare, basically the US government back then, I'm not sure if it was called Medicare back then, basically said, yeah, we should pay for this because people are going to die. And the way that the first benchmark for how much you would pay for somebody's life came into being. Okay. And that was $50,000.
That seems very low.
That's actually relatively speaking high, because that's like every, you know, like that was the line in the sand. Yeah, that was the line in the sand, how much I would pay basically to improve your life by a year.
Okay.
So if this keeps you alive one more year for $50,000, basically pay for it. Because back then dialysis cost $50,000.
Oh. Okay. Okay.
But here's the thing. That line in the sand has not changed with inflation.
Are you serious?
It's still the same line.
Oh dear.
It's still the same line, because the other direction has happened is like cost savings. You know, like all these healthcare funds basically, you know, can't afford for this aging population and shrinking workforce. And so you do things for cost savings. Right. And so now every time you want to justify a new treatment is not just safe and efficacious, but actually provides a substantial benefit per dollar, basically, as compared to another treatment option. You have to do a healthcare economic study to justify what your QALY is.
Yeah. Okay. 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 Okay.
Yeah.
Okay. Yeah. Okay. Let's work. I like it. There's so many. It's such. Yeah. No, I really think it's a good one. I'm just trying to think how we can put it in in a funny sentence.
You need to find somebody who is just naturally very punny.
Naturally,
Unfortunately, I'm not punny at all.
Actually, that's a good idea. I should ask people, punny people. Okay, yeah, we can work on that. We can work on that. And then we'll use that. Okay, good. And okay, okay. So this is like just some work follow up stuff. Did you manage to go into the document and kind of put in like your descriptor, like how you intro yourself?
It sounded so stupid.
Why?
Imagine what I wrote.
No, it doesn't sound stupid. What do you mean? What do you mean it sounds stupid?
I don't know. I was trying to be like all fun and friendly and stuff, and I'm just like, this sounds stupid.
Can you please give me an example of what you mean?
Let me see. I think I
Okay.
wrote something down somewhere.
You wrote it on a piece of paper.
I was trying to like brainstorm.
Okay.
Yeah. So I think I did. I say, hi, my name is Yan Lin, your medtech industry insider, and your awkward friend who talks about industry so that you don't have to.
No, I like it. What's wrong with that? That's so cute.
I know, I feel so awkward.
Why?
But I was like, I don't know. So it's like I have a few variations that was like, your awkward friend who talks about industry at dinner parties so you don't have to, something like that. So yeah. I
really like the first one, and the reason why I like it is because I think in this platform you have to reveal, like, you have to be a little bit vulnerable, right? You have to reveal a little bit about yourself by kind of putting your personality into it. So that's really like your personality is how it comes across. Then it's perfectly fine. I don't think it needs to be polished.
Okay.
As long as you're comfortable with it, is what I mean. Yeah. Because I'm very comfortable with it. I think it sounds great.
Okay.
Okay.
Fine.
Good.
Right. So we're almost there. We almost have a name.
We almost have
an intro.
Once we have the name, we can put it in the intro. It's very easy. Yeah. So that one's just something we probably just need to sleep on, and then we'll get it done. Yeah. Yeah, maybe. Okay, so let me sleep on it and think about it a bit, and then maybe if we have some time over the weekend, if you have some time over the weekend, we can do. You're out on Sunday or Monday?
Sunday. If you want, you can have dinner with lunch with me or something on Sunday.
Wait, are you really completely out like Sunday morning?
I'm out 12:30.
Ooh, okay. So you have a checkout. Yeah, for sure. Let's catch up. Let's catch up then. Okay. Ken, we'll set it up.
Yeah.
Wait, do you wanna do some recording tomorrow, or do you wanna just chill?
We can. I don't know.
Let's just fix on the name first. Let's not stress out about it. Let's fix on the name first, and then as soon as we have something to come back at, then we can come back on it.
Yeah. Okay.
All right.
Sounds good. So I'll see you Sunday.
Yeah, I'll see you Sunday. Have a good dinner.
Okay. Thanks.
Bye.
That was QALYfied episode 0. In the next episode, find out, does Yan make it out of quarantine? Do we come to a consensus on a name for the podcast? The answers won't be a surprise, but you know what? Tune in anyway, because we'll be talking about the big C, testing, and life under lockdown in a 5-star luxury hotel. If you like what you heard, please leave a positive review on iTunes, Spotify, or wherever good podcasts are distributed, and recommend QALYfied to a friend.